It's still predominantly men here in Chicago, but it is older African-American men who are being disproportionately impacted. And when I say older, men between 45 and 64 disproportionately dying. And there's multiple reasons why that may be true, but some of it is that if you've got people who, may have been using opioids for many years, when a very strong version like this fentanyl kind of comes in, older people may have more underlying conditions, heart conditions, et cetera, may not be able to sustain, be able to live through even with an attempt to reverse an opioid overdose. And so it's meant that the strategies that might have worked in a rural setting just don't really apply here. And we don't have enough treatment available either. So naloxone is not treatment, but it's the emergency medication that can be given in the nose or injected. And it's a life-saving medication, like an EpiPen that, anybody can
the
give
Lazarus
someone.
Drug is
yes,
what it's
exactly.
called.
Right. Anyone can give that after an opioid overdose, and it saves somebody's life. And then you call 911 and get them into the, into the emergency medical system. But then after you reverse an overdose, you also need to actually get that person into treatment, right? And making sure that we're promoting the best evidence-based treatment that's available, which includes using medications. And there are medications that primary care physicians can prescribe for this, for example. The health department's been focusing on, what we call harm reduction. So things like making sure naloxone is available, that for people who use drugs, we're sharing messages about safer ways to use drugs, to work to limit stigma around this, to think about prevention messaging. That in the treatment space, we've been working a lot with healthcare providers, outpatients, emergency departments, funding in those spaces, but also just helping connect best practices. And then we've tried lots of sort of novel pilots, things like following up with people at home after overdose. And is that a program we can expand? Community health workers, particularly who can focus on these disproportionately affected populations. So, working very specifically to make sure resources are getting into African-American neighborhoods, or that we're thinking about how messaging might reach older people, for example. So it's been a really interesting one because it came very quickly and it's multifactorial, and there's still so much stigma related to people who use drugs. These are things that we're used to as a health department thinking about for other diseases, but the fact that people don't even realize how big a problem the opioid epidemic is here in Chicago makes it hard to, galvanize the kind of support that may be needed. So, Mayor Lightfoot and her team have been really interested in doing more in this space, which we're excited about. We also, Chicago Department of Public Health, successfully got our first real substantial federal funding in this space just last month. So that gives us some more resources to be able to build out programs that we know work. But you can have a list a mile long of what you want to do, but you do need resources to be able to make it happen.
Certainly you need a multi-pronged approach to addressing this issue, but what is if you were given resources to fund one initiative to combat this issue, what would you put that money into? Is it messaging? Is it...
I think if I could choose just one thing, I always, whatever you're going to give me, I'm going to want to divide it up and do multiple things. But there's a practice that I'm really interested in, which has been shown to be effective in some other jurisdictions, which is this idea that after you've reversed someone from an opioid overdose, you are following up with them at home a couple of days later. Because right when you reverse someone, it is not necessarily the moment to try to engage in treatment. I mean, we'll try, but people are having physical cravings. There's a lot of, in a busy emergency department may not be the place. And if you're able to have a social worker, somebody who knows a lot about treatment, is not going to be stigmatizing, sort of come out a couple days later, work to make sure that the patient's family and friends and anybody who's around has naloxone, is trained in it, and then really work to connect in a very warm handoff kind of way those folks to treatment. I think that would be a big step in the right direction. In Illinois, people who die of opioid overdoses hit the healthcare system an average of 6 times in the year prior to their death. So those are 6 opportunities to potentially try to link people into care. So I'd love to say prevention, and that's a big piece of it, but when we're at the numbers we're at, we need to save lives and we need to work on treatment, I think, first while we build the prevention space.
Okay, so one of the things that I thought was interesting in reading Lori Lightfoot's announcement of nominating you as commissioner was thinking about the way that public health can contribute to the mayor's vision of a more equitable city. So I'm curious to get, from your standpoint, from your experience, how can the Department of Public Health play a part in the overall agenda?
Yes, thank you. So one of the reasons we were really excited to have this new mayor and her vision is that what she and her team are wanting to do is so in line with what we've been trying to push at the Chicago Department of Public Health in recent years. So our last sort of community health improvement plan was called Healthy Chicago 2.0. You can Google it if you want to see the details. But the subtitle on that was Partnering for Health Equity. And we started doing things like measuring our success, not by whether the city as a whole is making progress toward a given outcome. You know, if smoking's going down across the whole city, great. But instead, let's measure success by priority populations that are most impacted. So for smoking, you know, say we're talking about adolescents, LGBTQ youth are much more likely to smoke. Maybe we focus resources, you know, toward that population. And success means moving that group more towards a health. And so especially where we see such great gaps in racial and ethnic health outcomes here in the city, I think it's really imperative on the health department to make sure that we are doing everything we can to address those and to put resources towards them. And so, you know, as we're thinking about kind of what's coming next under this new mayor, we're focusing a lot on the things like life expectancy gap here in Chicago. You probably know that depending which neighborhood you live in Chicago, there can be a 17-year life expectancy gap in between neighborhoods that are just a few L stops away from each other. That's not acceptable. And if we take a sort of a race ethnicity look at it, for example, the life expectancy gap between Black Chicagoans and white Chicagoans, any idea how long that is?
I've seen this before. It's too long.
It is, yeah. It's about 8.8 years for all comers. And so we've looked at what are the major drivers of that. You know, the biggest one is chronic diseases, especially cardiovascular diseases, things like, that can be driven by obesity, can be driven by tobacco, cardiovascular disease, diabetes, heart disease, some of the related cancers. That's the biggest. That's 3.8 years of that 8.8 year gap. But next comes homicide at 2.1 years. Next, infant mortality, still very disproportionately still impacting Black communities over white ones. Next is infectious diseases, including HIV. And then rounding out the top 5 are opioids, actually. And those are not the biggest causes of death in Chicago, but they're the ones that drive that gap the most. And so as we're thinking about kind of our next plans, in each of those areas, we're really trying to focus in on what programs can we be developing? How do we need to fund this work? How do we measure outcomes? And we talk a lot about root causes is the other thing. So it's not just about our folks getting health care for these things. Certainly you need health care if you have HIV, you need to be on medications. But so much of what drives health is outside the healthcare system. This is what public health is about. So is your neighborhood, safe? If you're wanting to be out and you're wanting to walk and you're wanting to do exercise, do you have good food access? Do you have economic opportunities? Do you have good educational opportunities? Like, are you in settings that allow you to live your healthiest life possible? And the mayor is really all about this kind of an approach. And so as the health department, we've been really excited to see the initiatives that we focus on and plan to continue focusing on being so supported and integrated with a lot of the work that team is doing.
So we talked earlier about how you're still a practicing physician, so you work a lot interpersonally with patients. And just now we were talking about a laundry list of very troubling and perhaps sometimes depressing data points around health disparities in this city. I'm wondering, with this level of secondhand trauma that you're exposed to on a daily basis in your role, how do you approach self-care?
Interesting question. I think when you're in residency as a physician, you're working all the time, nearly all the time, kind of when you're awake. And you're constantly, it's not about you, it's about the patients who are very often really ill and not having, depending on the setting you're practicing, not having a lot of resources available. And, especially if you're working in an inpatient setting, when I think about some of these statistics about things like heart disease, like I flash right back to patients that I've taken care of, right? Who, come into the hospital and regardless of whether they have insurance, will do what is needed to save their life, right? Like we'll bring them to the catheterization lab and, help make sure after a heart attack their heart is functioning well. But then when they go, they may not be able to get the medications and the support for lifestyle type things that would be needed to keep them from coming into the hospital again. So for me, there's the patients that I take care of, and then there's these data pieces that I do every day, and they inform each other, but they don't, you have to kind of have a certain amount of, I don't want to say distance from it, but to be an effective physician, when I'm taking care of a patient in front of me, right, I'm thinking about, here is my patient. What issues does this patient have? Let me diagnose them, and then let me think about how I can treat them. In my public health role, I'm thinking about the community as the patient. What issues are affecting this community? What might be most needed to treat these issues? How do I prevent these diseases to start with? And they're different processes, but at the end of the day, every one of those statistics is a person anyway. For me, the self-care is as much about being able to work on that on the policy side, right? Like thinking about what can we do as a city to build better systems so people can access care and get the mental health care they need and get the insurance and have access to food. And it lets you feel like you're really doing something about the big problems, which keeps you from getting too depressed with the individual patient issues, I would say.
An answer befitting of a brilliant public servant. Thank you so much.
Yeah, I just want to say I think that that's such a great example of why it's so important for, individuals who are policymakers or working as elected officials, why having those face-to-face interactions with the people you serve or the communities that you're studying, especially when there's so much emphasis on looking at data points and statistics, why having that interaction is so important for informing that work.
Yeah, I couldn't agree more. I think, a lot of what we do here is really try to get out to communities, talk to people about their ideas, what works in those settings. It's the same as when I used to work in Liberia or any, you don't just show up and say, here I come, I have the idea of how to solve your outbreak or how to address, some issue that you probably don't even have fantastic understanding of all the underlying pieces. It's the same when I'm going into a community area, even though it's in Chicago and Chicago's my city, there are obviously very different issues depending where you're living. And you got to listen to folks and really take the ideas that they have of how to make the best communities possible. And we really see our role as the public health department as helping kind of coordinate among these ideas and make sure everybody's rowing in the same direction so that we're thinking at this big systemic level about not just how to treat people with the disease, but how to keep people healthy and build on the strengths that are in, these communities.
We're going to dive right into Chicago hot takes. Steve, you want to take it off?
All right, Dr. Arwady, what is your favorite museum in Chicago?
Oh, probably, I have so many. I'd say the Art Institute. I used to work across the street from it, and it was my getaway when it was really cold.
Favorite Chicago staple food?
Forget you're a doctor for this one.
I don't really like hot dogs. And the deep dish is not really my favorite. I go more for the thin crust. I like the fact that Chicago's got a lot of interesting ciders on tap when you go out, not just beers. I think it's unusual, and I really like cider, so I'm going to go with strong cider presence.
That is a hot take. All right. Favorite restaurant in Chicago?
So Batter and Berries is, do you know it? It's a brunch space up north, and they just make amazing breakfast food, and there's a long line, but I don't mind waiting in it.
Does the batter refer to pancakes and waffles?
It refers to pancakes and waffles.
I'm
there. Really good.
Favorite Chicago neighborhood?
So I never like to choose just one Chicago neighborhood. I've lived in multiple, but can I throw out one little thing? So I I didn't tell you this, but I lead tours with the Chicago Architecture Center.
Oh, really?
Yeah. And so I do walking tours and I do the boat river tours. And so, yeah.
All right, when do you do the boat river tours for our listeners?
I do them with some frequency. Yeah. When I'm not working. So on the weekends and sometimes in the evening. So I would say my favorite neighborhood is going to be the one that I'm learning for a given tour, because I really dive into, that history, and I get to know the buildings and I get to know the pieces